Next, we have Dr. Linda Inkpen of the College of Physicians and Surgeons of Newfoundland and Labrador.
Thank you very much. I'm excited to come here today to speak, although it's not an issue that the college usually speaks on. But despite my excitement, I'm tempered with my husband's comments this morning. And early for breakfast, I asked him to read what I was going to say, and he said it was the most boring thing he'd ever read in his life. So that either says something about me or him, and I prefer the latter. So bear with me, please. Thanks again to Dr. Locke and his colleagues for the invitation to speak at this health forum. But I think it's very important to be clear up front. The college's role in relation to healthcare outcomes and costs is indirect, but we are a partner institution involved in healthcare delivery in this province, and we welcome the invitation to share information and add our voice to this discussion. The college has been in existence since 1893. The original mandate, defined through an act of legislation, was remarkably similar to the legislation passed in the Medical Act 2011, under which we operate today. Essentially, we regulate physicians so that the public receives competent and ethical medical care. That is, we regulate to ensure that physicians provide high standards of practice, we provide continuing physician competency programs, and we develop and enforce physician standards of practice and practice guidelines. What we do not do is make policy that directs how and where money is spent by individual physicians, clinics, hospitals, or governments. And I have been reminded many times by other Canadian college registrars that colleges of physicians and surgeons are regulators of physicians, mostly individual physicians, and are not regulators for healthcare systems or institutions. The college organizes itself into three main areas of operations: physician licensing, overseeing and operating physician quality assurance programs, we can talk later, Pat, about that, including college policies, and handling complaints against physicians. We do all this with foremost attention on our mandate. The college exists to protect the public. We are not an advocacy group for Newfoundland and Labrador physicians, Lynn. All colleges of physicians and surgeons in Canada operate with similar mandates. But we are also all creatures of provincial legislation, and therefore we operate with our own provincial peculiarities in the broadest sense. All this said, the regulatory world is not a black and white world. We cannot regulate physicians without recognizing that they are integral partners in the delivery of health care and that their services are highly integral to healthcare outcomes and healthcare costs. Here's a closer look at what we do and what we don't do. The colleges, for the most part, do not develop clinical guidelines. The certifying colleges, such as the College of Family Practice in Canada and the Royal College of Physicians and Surgeons in Canada, they set clinical guidelines, for the most part, with significant major partners such as the clinical specialties and subspecialties, and they have the expertise and experience to pronounce on clinical guidelines, efficiencies, outcomes, costs, and I mean costs financially and in terms of patient safety, of performing or not performing specific medical procedures or investigations. The licensing and regulatory colleges, such as our own, then hold physicians accountable for having the expertise and experience to work within up-to-date clinical guidelines. We do this through our continued physician competency programs, of which major components, no surprise, continued medical education, and on-site and off-site peer assessments. So, number one, colleges do not develop clinical guidelines, but we do hold physicians accountable to set clinical guidelines. And colleges do not undertake physician workforce studies. But there is an inescapable connection between licensing authorities and professional workforces simply as a result of colleges requiring qualifications to enter the medical profession. Our college is governed by a council. Its members are physicians and non-physicians, elected and appointed. Council devotes considerable energies in 2 major council meetings a year to specify the work the college must do, the work expected of us, and the work we want to do. Within a budget of little over $3 million, all collected from physician fees, no other monies, only physician fees, this work can appear daunting. However, we perform an annual strategic review through which the College Council considers the College Risk Assessment Register, reviews past and proposed college operational plans, reviews college vision and values, guiding principles, and sets goals, objectives, and priorities for the coming year. This work is a huge endeavor for a small college, but is critical to keeping our college on task and focused as we, too, are buffeted by emerging daily issues and challenges. The college has a mandate, or I should say our college has a mandate, similar to that of even the largest medical regulatory college in the country. We have 13.5 employees. Ontario has 400. Our college devotes well-spent time to Canadian jurisdictional scans for policy review, licensing standards, complaint handling, and all operational issues, learning from other colleges, and reviewing and revising their work to fit the Newfoundland and Labrador context. We thank our Canadian college colleagues whose work and research in many cases underpin the work we do here in our own province. It's a great way for a small college, read small province, small everything, to learn from other successes, tribulations, and also, in some instances, quite frankly, what not to do. Our Newfoundland and Labrador College reviews our value statements, again, our guiding principles, each year. And our 6 college value statements for this year are fairness. The college undertakes to treat all individuals and organizations who avail of college services with fairness and consistency. Quality of service. The college undertakes to provide quality service in a timely way to members of the public, college members, and other stakeholders. Social responsibility. The college undertakes to pursue social responsibility issues where they fit within the college's mandate. Communication. The college undertakes to assess the opportunities for communication in all its work and execute them where appropriate. Transparency. The college undertakes to embrace principles of transparency in all its work, recognizing transparency as a sustained commitment to share information while balancing the needs for both patient and physician protection and privacy. Innovation. Our last guiding principle. Our college undertakes to apply to an innovative screen to all our college work. No small feat. The college endeavors to pay heed to our value statements in all our work and core activities. I suggest that all of these values have an impact on healthcare outcomes and healthcare costs. However, I want to speak to just a few of these this morning. Social responsibility. The colleges in Canada pay close attention to the work and publications of the Federation of State Medical Boards in the United States. We are also members of the International Association of Medical Regulatory Authorities. It is somewhat comforting, cold comfort maybe, that the issues even the Atlantic provinces colleges face are mirrored in the discussions in the American state boards, in Australia, New Zealand, the General Medical Council in the UK, and elsewhere. A major theme across all regulators, and not only health regulators, is how to balance and contribute meaningfully to addressing workforce issues in a regulatory system that by its very nature is not designed to address such issues, while we are concentrating our efforts on maintaining, in our case, physician licensing and practicing standards. Because demand for physicians is greater than current supply, this college experiences daily, often hourly, the system push to license quickly and take shortcuts with standards processes to meet a crisis demand for a physician in an area of real or perceived underservice. These market-driven decisions and forces must not supersede our college's accountability and responsiveness to maintain standards for public protection. And of course, this leads to the larger discussion on more improved models for healthcare delivery without abandoning core responsibilities to regulate with the best interests of the public in mind. So how does a college such as mine value add in this debate? How can we help in identifying healthcare system potential solutions? Our first and best answer is we have data. Indeed, we are most often the source of truth for all physician data in our province, physician data in our province. The Canadian Institute for Health Information Statistics, the Newfoundland and Labrador Centre for Health Information Data, Memorial's research activities all draw on college data, which is not to say that we always have informative data for every question, but we do have some important baseline information about physicians in our province. Until the last year or so, while attention was always paid by our college to data collection, it was really in the absence of a robust and modern database. We are now in the second year of a new database installation and implementation, and the college is extremely pleased with the database applications with which we are now working. They can do more to inform physician workforce planning for the institutions and agencies who might use this data for physician workforce planning purposes. We want to share this data. That is, as much as we can while following guidelines of appropriate application and our own administrative procedures. Relevant and reliable data must be the foundation on which credible planning is built. Our college is small and our capacity limited because of our ongoing mandated work. But when requests for data are timely, our college can provide programmers and programs with access to our new database information for many, many purposes. Needless to say, in 2018, we are challenged with what data we can collect and in what form, and what data can be shared and in what form, not specific to us. We have to ensure both member, read physician, and public privacy and adhere to all legislative acts and regulations in that regard. Our college is not unique in constantly reviewing and discussing these concerns. In this day and age, information privacy is paramount. Here are some examples of the kind of statistical data we can provide. All three of the following slides are taken from the college's soon-to-be-released 2017 annual report. I'm not going to read them, but I'll just leave them for a few seconds. Over the last several years, the college has devoted considerable effort in identifying and improving upon our communications and assessing our core activities with a transparency lens. The goal of this work is to better inform the public, for whom we exist to serve, as well as our college members, again, read physicians, and agencies and institutions about the work the college does. Sharing information also helps engender public and member trust that we perform our work as publicly and openly as possible. This communication work spans a spectrum from expanding information about physicians on our medical registers, that's public information available on our college website, to communicating and promulgating college standards of practice and practice guidelines for our physicians. All efforts support the premise that quality-informed medical care promote a cost-effective healthcare system. I trust that further research on this issue, Wade, will continue to support this hypothesis. It will be increasingly important in the current environment for medical regulatory bodies to exercise thoughtful and clear decision-making when they establish council policies and when they pronounce on any council decision that directly or indirectly touches upon the marketplace. It is critical that all market-driven decisions be informed by and balanced with data and policies that reflect accountability and responsiveness to the public interest. Innovation. In almost every professional sector, and healthcare is but one example, we are seeing exponential increases in knowledge, communications capabilities, and technological innovation. Technology is a key transformative agent in healthcare delivery and its costing, and particularly in sparsely populated regions, provinces, and even countries. As a value statement, innovation is relatively new to the list of our college guiding principles. Our medical regulatory college undertakes to apply an innovative screen to all college work. We have to recognize and act appropriately to accommodate potential, newer, evidence-based models for physician practice standards and guidelines without abrogating our responsibility to regulate to set standards. And we must do so where such contemplated forays may not really fit neatly within the college mandate. For example, the college has defined in some circumstances and is exploring in other circumstances changing virtual healthcare delivery, including traditional telemedicine and expanding the healthcare data environment, but all with a public protection focus. Much work has been done nationally and internationally to provide resources to medical regulatory authorities, colleges, so that they can develop and incorporate regulatory strategies that will increase collaboration among healthcare professionals. Some writers posit that traditional demarcations between medical professionals are increasingly out of step with the realities of the 21st century. there is a call for all stakeholders to take steps that enhance interoperability and increase uniformity in all practice settings. Our small college is challenged regularly with public concerns, read probable patient safety concerns, with our healthcare system because it often comprises so little interoperability and has so many concerns for patients and practitioners when it comes to continuity of patient care. All of us, consumers and providers of healthcare alike, are hearing about thought-provoking and game-changing innovations, such as those recently described in The Economist's articles on digital healthcare. These innovations can empower patients, improve diagnostics, lower costs, and improve healthcare outcomes. Note that the recent and former Economist healthcare-related articles are to be found in the magazine's business sections. Along with innovations, however, come complex new ethical questions, quandaries, and debates as physicians incorporate new tools such as social media and electronic medical records into their offices and into their practices. And we must ask, will devising innovative approaches to healthcare delivery lower costs in our very small healthcare sector and economy? If yes, when? For what saving? What unforeseen consequences? A recent article in the Journal of Medical Regulation, it's an American journal, addresses the novel dilemmas presented by the modernization of healthcare and describes some of the healthcare consequences if the pitfalls of modernization are not addressed. The article illustrates how the increasing innovations and complexity of rapidly changing modern healthcare require more physician reflection and discernment and greater exercising of professional judgment, not to mention technical training. All of this comes at a cost to physician well-being and in some instances productivity, which in turn contributes to burnout. In other words, innovations that save time and increase interoperability may also add significant personal, system, and financial costs. And I'm sure Lynn will most assuredly speak to physician well-being and its direct and indirect costs to healthcare delivery. What are the cost projections for innovative healthcare delivery in the years to come, or perhaps I should say months to come? Such changes are coming very, very rapidly. How does a small population base in Newfoundland and Labrador fund healthcare delivery today and transition to modern healthcare delivery tomorrow? Is there an interim higher cost? All good questions for the thousands of economists who are in this room today. In conclusion, I have, in the course of this presentation, explained what the college mandate directs us to do. I have described what the college generally does not involve itself with. However, I have opened the door on how the college can assist others in exploring physician workforce resources, healthcare outcomes, and healthcare costs, all under the rubric of our college value statements of social responsibility, communication and transparency, and innovation. I have spoken to the role of the college, albeit indirectly, but not inconsequentially, in Newfoundland and Labrador healthcare, and posited the challenges and potential solutions and queried short-term and long-term costing of an inevitable public call to modernize our healthcare delivery systems for this 21st century. Dr. Locke asked that the participant speakers attempt to answer specific questions. Ever the obsessive and obedient student, and damn good one. I dare not speak around the issue, but I'm going to provide the following comments. My responses are a composition of ideas, thinking, actions gleaned from a variety of sources over my 3 years as registrar with the college, but many, many more years working in education, in the corporate world, and as a practicing physician. My comments do not reflect a formal college position, although many colleagues have kindly read this presentation. First of all, what can the college do to improve healthcare outcomes and healthcare costs? Question number one. The college's major, but not only, contribution would be, in my opinion, data access, albeit controlled, to physician resource data and information. What could our Newfoundland and Labrador government do to improve healthcare outcomes and costs? Use reliable data from all sources so that planning is founded on sound cost of delivery information. Explore the advantages and disadvantages of creating a single Newfoundland and Labrador Regional Health Authority. Other provinces have moved in this direction. Some, most, my understanding is with favorable comment, some not so. But fully articulate at what dollar savings and at what cost. Better system, interoperability, and more uniformity would certainly provide better patient services and probably safety. I'm talking about better patient outcomes. What can we individually and collectively do to improve healthcare outcomes and costs? Abide by evidence-based practices such as choosing wisely. But practitioner and patient buy-in has got to exist. Learn from other healthcare providers what has worked and what hasn't, and at what cost. Define cost clearly. Adapt relevant existing models of healthcare delivery to the Newfoundland and Labrador context. We do not have to reinvent the wheel. Is there a legitimate role for private healthcare incentives? The private-public healthcare interface and its incumbent issues have been discussed, implemented, and assessed for years in other Canadian provinces. In 2018, it remains a valid question. Learn from other colleges' endeavors. Ask the public. Ask healthcare providers. Meaningful consultation is imperative. A one size does not fit all in Canada. Is public funding of healthcare a basic right or privilege? Depending on fiscal realities. The Canadian question. It's not just a Newfoundland question. Most Canadians agree that one of the essential ways we as Canadians define and distinguish ourselves is through public funding of healthcare to be a basic right. Does this hold in 2018 as it did in Mr. Douglas's time? To answer this question, we need not only the broadest of consultations, but also to be very clear about how we are defining the embedded terms. How do we as Canadians define public health care? How do we define the public good? I believe this public policy discussion must take place in the most open and inclusive of Canadian settings. And I add a plea to governments. Articulate how you are defining your values, and please understand that what you permit, you promote. What you permit, you promote. Review what you have been permitting, maybe revise, but enforce it meaningfully. Treat us all with fairness and consistency. Should entitlement to health care become conditioned by personal responsibility? Everything I have heard and read suggests that Canadians strongly disagree with this proposition. This is certainly not the health care that my family, my friends, and my colleagues envision. Wade, I hope other speakers hit them off 1 to 6 in the same way I did. Thank you very much. And if anybody has any question, I'd be pleased to try to answer it.
So if you have a question, we'll get a mic to you. Dr. Tomlin, again, in the back.
I was interested in when you started, you said that you're not an advocate. You don't have kind of an axe in the game. And then you talked about data and the truth associated with data. And I mean, how we construct information, how we frame questions is a source of power. What is the problem? What is the nature of the problem? What are the solutions? So I think part of the challenge or problem, I think, with healthcare is that we have all these various interests and they have ways of constructing information or knowledge. So when I was working with the Romano Commission, I was looking at civic or citizen engagement and looking at how knowledge is constructed. And there are clear biases in terms of the interests which are driving knowledge and knowledge construction and framing the questions and deciding which forces or sources of knowledge exist, what networks exist. So I think part of the conversation or challenge has to do with recognizing that public policy is often used for political purposes, for mobilization and so it's not just evidence-based, which is basically about truth. The construction, the reconstruction of truth is based very much on interest and what we pay attention to, what we don't pay attention to. So I think we need to start off with an understanding that people who are constructing knowledge do have an interest.
Thank you very much. There was a question earlier this morning of where's the authority, where's the power to effect change? And yes, we go to the ballot box every so many years, but there are very few other bodies in healthcare, there are a couple, that have the authority that our college has in giving licenses every year to physicians. We control physician licenses. We decide what questions we will ask on annual renewals or when physicians come first to practice in Newfoundland and Labrador. We have data that we collect for our own purposes, but we have also able to collect other data for other purposes because we have the hold on 1,400 physicians each year. Now, we do not use that tool without a lot of thought or consideration. And when, Dr. Tomlin, you come and say you want access to our data, or will you ask A, B, or C, we will stop and consider it. But we collect data, we can collect more data, but remember, data is not information. We cannot control the questions you want, the question society wants and how they want to answer it. But if our data can help inform that debate and discussion, then we are very, very open to it.
Okay, another question. It's over here in the middle, Lynn, on your side.
Hi, Dr. Inkpen. Thanks very much for your presentation.
Was it
I'm Chris
boring?
Aubrey.
Was it boring?
I don't think so.
So.
Chris Aubrey from the Faculty of Medicine. Just wondering, my interpretation of some of your final comments there, I found them a little bit vague, I guess. No offense intended. Just wondering if we could clarify the position of the college on the payment for, not funding necessarily, but payment for medically necessary health services. I wasn't sure.
We have no stand on that. That's not
Okay.
our business.
Okay.
Right there. Thank you.
I'm David Thompson. I'm a patient. I don't understand exactly what the college does, despite your careful analysis of it. Could we take a specific example? If it is correct that according to your data, physicians in Newfoundland overprescribe antibiotics by perhaps 100%, what power does the college have to change that?
I can answer that. I hope I can. We do not set clinical guidelines, so we are not the body that will decide if we underprescribe or overprescribe any drug, or if we underprescribe or overprescribe any test. We follow clinically set guidelines. But, and I'm going to speak to my NILCHI colleagues here right now, we have the ability through any number of ways to monitor what's going on against set standards and to take intervention. Right now, this province is in the early stages of developing a fairly robust prescription monitoring program that, for the most part, has got narcotics and controlled substances in the back of its mind. But such a program can also be used to monitor physicians on if they're overprescribing or underprescribing certain other medical treatments, including medications, including tests and investigations. And then when that information comes to us, filtered down, we then have the ability to go out to the individual physician and say, Dr. Locke, your profile shows that you have been prescribing far too many antibiotics or far too many narcotics. Would you please explain your actions? There may be a good reason. Maybe he's got a palliative care practice and he prescribes more narcotics, or maybe he's got a terribly ill population that the antibiotics will be up. But then with going out to that physician and asking these questions, we can then hopefully work with that physician to find out what the practice issues are and whether they need to be changed. So no, we don't set the guidelines, sir, but we can monitor those guidelines and deal one-on-one with our physicians who may be outside the range of those guidelines to effect more quality care. Fairly put, Pat?
Okay, and one more question from the audience, if we've got anything. Oh, just in the front here, Lynn.
Hi, Roger. Roger Chafe, Faculty of Medicine. Just to follow up that question, has the college actually done that with physicians here in Newfoundland? And I wonder, are there colleges across the country that are probably a little further around going down that path of looking at practice guidelines and kind of trying to enforce them using the college's authorities?
We do so all the time, quietly. But the problem is the issue comes to us through anecdote and through comments from other physicians or pharmacists. But with a proper monitoring program, such as we're starting with the prescription monitoring program, then we will be more structured in our ability to do that. But yes, we do it all the time.
Great. Any more questions from the audience? Okay, I think we're seeing lots of emerging and common themes today about communication and openness and getting a debate going. So thank you, Dr. Inkpen.
Thank you.